us. And Ashley and Joanna, if you can just let us know when you're ready, we'll get rolling.
Looks good on my end.
All good on my end too.
Okay, thanks so much, Joanna and Ashley. Really appreciate your support of these media briefings. And good afternoon to all of you, and thank you for joining us. My name is Taya Briley. I am the Executive Vice President for the Washington State Hospital Association. As we come to the close of 2021 and prepare for the next 2 weeks of holiday gatherings, we wanted to share with you some information about the current status of hospitals in Washington State. Given that there's this fast-moving Omicron variant and the significant healthcare system overwhelm that's currently happening in our state, we didn't feel like we could wait until after the new year to connect with you all again. And I am glad to have with us today 4 excellent panelists who will be able to give you information and updates from their various perspectives and from their communities. We have Dr. Michael Mint, who is the Physician Executive for Population Health for Multicare Health System, and Dr. Jason Lake, who is the Chief Medical Officer for Confluence Health in Wenatchee, and Mark Taylor, who is a registered nurse and the Director of Operations for the Washington Medical Coordination Center, which is based at University of Washington's Harborview Medical Center, and Dr. George Diaz, who is the Division Chief of Medicine and Medical Director for Antimicrobial Stewardship and Infection Prevention at Providence Regional Medical Center in Everett. I'd like to start out with some comments about the Omicron variant of COVID-19 and how it intersects with hospital capacity. Omicron is serious and it is rapidly spreading, and honestly, our heads are spinning a little bit about how fast it is spreading. We heard earlier this week from our partners at Seattle-King County Public Health that they expect the COVID-19 case rates in this area to be higher than our previous COVID-19 peak by the end of December. Hospital capacity is already more strained than it has been at any point during the COVID-19 response, with many hospitals and health systems currently operating at or even above 120% capacity. As we've mentioned before, the strained capacity is not primarily driven by patients hospitalized with COVID-19 or even those who need hospital care at all, and we'll talk more about that in a moment. Right now, surgeries and scheduled procedures are being canceled and patients are being cared for in hallways and waiting rooms. That's the reality of being at the level of capacity that hospitals are right now. Like you, we are hearing some early reports about Omicron and that individuals who contract the Omicron variant of COVID-19 don't get as sick, and perhaps fewer of them need hospital care. However, we have a math problem. And that is, even if most people don't get really sick, there are a lot of people who are getting infected with Omicron, and some portion of them will get severely ill and need hospital care. Even if it's a small portion of the overall total, this could mean a huge number of people getting sick enough to need hospitalization. And they're going to be needing that hospitalization in a system that's already more than maxed out. We are also very concerned about the transmissibility of Omicron and how that might affect staffing. Even if staff don't get super sick from Omicron, it still is going to affect their ability to come to work as they need to isolate themselves. Our biggest concern in facing an Omicron-driven surge remains a lack of hospital capacity. And remarkably, our COVID-19 numbers, with the exception of a couple of areas, and Pierce County is one, are down. And our COVID-19 numbers actually look excellent compared to many other parts of the country. There was an average of 575 COVID confirmed hospitalizations this past week compared to the prior week's average of 626. This is an 8% decrease in a week, or an average decrease of 51 hospitalizations. The 7-day average of patients on a ventilator was 86, which was a 15% decrease on average 15 fewer patients compared to the prior week's average of 101. And sadly, COVID-related hospital deaths do continue, and last week they were an average of 12 to 15 a day. Despite more positive COVID hospitalization numbers or trends, hospital census already looks like we are in the midst of a surge. As we've said before, the thing most driving these hospitalization numbers is the fact that patients who don't need acute care are stuck in hospitals, and they really need to be in more appropriate settings where they can receive the type of care that they need in a more community-based setting like a nursing home or other long-term care. Unless we can move these long lengths of stay patients to non-hospital settings immediately, we are not sure we can take care of everyone who needs it if we get a big spike of COVID hospitalizations. Over these past months, we have shared our ability to successfully manage COVID-19 spikes and to care for everyone who needs it. We're feeling differently about that today. Hospitals are working all the levers that they possibly can to reduce capacity or prevent people from needing hospitalizations. They're working with their communities to increase vaccinations and increase boosters. They're urging members of their communities to take all the steps they can to not get COVID. They're making internal changes to create faster discharges out of hospitals for people who don't need long-term care. They're moving procedures to outpatient settings so people can go home the same day. Sometimes this creates extra strain on a family when patients would normally be in a hospital for a day or two, but it's positive that people are able to get the procedures that they need. Hospitals are educating their communities about when to seek care so that people that are sick but don't need emergency care don't further stress the system. And we expect many who contract the Omicron variant of COVID will be able to successfully manage their illness at home. And hospitals are providing primary care to those who have chronic conditions to make sure that they don't get sick in a way that requires them to go to the hospital for treatment. We have repeatedly described the challenge with patients who don't need to have care at the hospital, but who are stuck in the hospital. And we've been working hard with our state partners on this because most of the solutions to this problem lie with the state. Most of the patients that are stuck in the hospital are patients that are with the Department of Social and Health Services as clients, or their Medicaid enrollees. And also in many cases, in the case of one of the areas of change, we need a change to state law. Earlier this week, hospital leaders met with key members of the state's team, and we feel encouraged that they are ready to help. We're urging them to move faster and do things in a way that's outside of their normal patterns. We're asking them to assess patients faster for placement in long-term care settings, and we're asking them to set the payment rates for nursing home care higher so that nursing homes can pay the staff at levels that will help them retain the staff they need to care for these patients. Yesterday, we got good news that the state is making progress on some of these solutions, and that will help ease pressure on the system. And we want to thank our state partners for working with us to address this situation. We also need bigger sustained changes to state law and funding for the state's long-term care system in order to ensure we don't solve this current crisis and then come back to this same situation in the future. The state legislature convenes in January, and we are hopeful that progress can be made on these priority areas during that legislative session. We also hope that the legislature is judicious and targeted with imposing new requirements on hospitals. New laws require staff time and precious resources to implement. In the past year, on top of caring for our communities in the midst of this pandemic, hospitals have implemented a vast number of new requirements, ranging from vaccine mandates to reporting public health data. And there have been many non-pandemic legal requirements as well. And we hope that the legislature can stay focused on measures necessary to keep our hospitals operating safely so they can serve our communities. Today, we're asking for the support of our community. Our healthcare system has been severely strained, but it is not broken. Your individual actions can make or break this response to the Omicron surge. We're asking people to layer their protections. We're asking them to get a really good mask, invest in high quality, well-fitted, medical grade disposable masks. Be thoughtful about holiday gatherings and events. Gather in small groups where possible, mask up indoors, maintain distance, and make sure you are in a well-ventilated space. Consider whether anyone attending your holiday gatherings are high risk and take steps to minimize that risk. Get vaccinated and get your booster, and make sure those that are at your gatherings are vaccinated and boosted. And I would note that there appears to be a really significant difference in severity of illness depending on whether you've been vaccinated, and our panelists can maybe speak more to that. Whether or not you're vaccinated, if you are experiencing COVID-19 symptoms, even if they're minor, please get tested, isolate yourself until you get a negative test result, and follow guidelines for care at home. And finally, we want to encourage people to appropriately seek care when they need it. We continue to see people waiting until they're having an emergency to seek care. If you have new symptoms or concerning symptoms, please reach out to your primary care provider or call a nurse helpline. And so that's the end of my remarks. Thank you for listening to those. And I am going to go ahead and turn to some of our panelists here to provide more perspective. If you have questions during the briefing today, please go ahead and chat them in, or after all the panelists have finished speaking, we can go ahead and have you all open up your, go off of mute and ask your questions. So I'm going to go ahead and start with Dr. Michael Mint. So Dr. Mint, would love to hear your perspective here.
Oh, thank you, Taya, and thanks for really, one additional thing is I'm an ID epidemiologist similar to Dr. Diaz, who you'll hear from later. And so I just want to double emphasize for my organization, Multicare Health Services, with 11 hospitals, mainly in South King, Pierce County, Thurston County, and Spokane counties. And I'll update a little bit on how we're doing, but I wanted to just emphasize what Taya just said. The key things are going to be our communities understanding how fatigued everybody is as long as COVID has gone on, as well as the understanding that family gatherings around the holidays are something that is our precious moments to ourselves and to our communities, that we continue to just be as thoughtful and cautious as possible, especially protect those that are most vulnerable in our community. I wanted to just emphasize also the importance of what Taya mentioned around vaccinations, if the vaccine series has not started, as well as boosters. So as an ID epidemiologist, I just want to emphasize that those who've had the vaccination series and when appropriate have the booster doses are protected from the more severe consequences of either Delta or the new Omicron variant. We are seeing that the Omicron variant, it potentially is less virulent or makes people less likely to be needing hospitalizations or potentially dying, but it's certainly not zero. We've had multiple deaths already documented with Omicron, and its rapid spread, we still don't have a full understanding of the longer term effects it has on our hospital systems. So emphasizing that booster shots and the vaccinations also. What I would say from our capacity perspective, to emphasize what Taya mentioned, is that it's very asymmetric throughout our regions. Being in multiple counties throughout Washington State, we see throughout the pandemic differential levels. And in fact, even in Pierce and South King counties now, we're seeing it slowly increasing rise, unlike some other areas in the state, which get lost a little bit when you look at the state averages in hospitalized patients. For example, after our initial peak in our Delta surge, where we've had over 150 patients in this region, COVID positive patients in our hospitals, we got down as low as in the mid 80s, and we're back up to 106 as of today. So we're seeing this kind of rising. And to Taya's point, there is a bit of a math problem here, because even if the percent of patients that require hospitalizations are lower for Omicron, which is now the dominant variant throughout Washington state, if enough patients get infected through the holidays, it may continue to strain our already strained systems. And to Taya's point, even with the lower levels of COVID patients, our hospitals have been running over 100% capacity. And we want to continue to be able to provide needed services to the communities for both COVID and non-COVID medical needs. What I would also say is that down in Thurston County, our Capital Medical Center also has been having varying rates of illness. And in Spokane, it's been relatively stable and luckily on the lower end, but we're seeing the rates in the community go up now. And we're anticipating that those rates in Spokane County may continue to rise. The last things that I'll mention in regards to our update is in regards to therapeutics. So Multicare, along with most other folks, the Washington Hospital Association, as well as the disaster medical advisory groups throughout the state, are looking at the efficacy of older therapeutics that we're going to have to retire, like monoclonal antibodies. Some of those that we've deployed don't seem to be as effective against Omicron, but we're partnering with the state with the newer therapeutics that have recently been FDA emergency use approved, both antibodies, preventative antibodies, pre-treatment and prophylaxis, as well as the 2 new oral medications out, to make sure that the patients that benefit most from these are able to get these as early as possible as our state starts to get these, and then continue to scale that as production ramps up for those therapeutics that hopefully will continue to be able to keep patients from having more severe consequences for COVID related effects. So I'll stop there and hand back to Taya for our next updates. Thank you.
Great, thanks, Dr. Min. All really informative, and especially appreciate the perspective on the therapeutics. There's a lot that's changing fast on that front. Okay, from there, I'm going to go ahead and turn to Dr. Jason Lake.
Thanks, Taya. So I just wanted to give a brief update regarding our health system and really our region. So first, addressing vaccinations. So our fully vaccinated rate in Chelan County is 62.4%, and our fully vaccinated rate in Douglas County is only 56.3%. And we track, obviously, the vaccinations that we're administering from our system, and most of those vaccines are booster shots, which are great, but there aren't that many new people entering the vaccination series. So I don't expect that those fully vaccinated rates are going to significantly shift over time, which could be problematic as we think about the Omicron surge. From a testing standpoint, currently, our volumes of testing that we do as an organization have remained pretty stable. So we have not yet seen a significant increase in demand. And we do require appointments for our testing. So we have a COVID hotline. So we'll see whether that changes as the demand for testing increases. Right now, our positivity rate for the tests that we do remains about 7%, which is honestly the lowest we've seen in quite some time. So we have not yet seen a significant uptick in that. From an inpatient standpoint, we have 15 COVID positive patients in the hospital right now, 14 of which are not fully vaccinated. So continuing to see that trend of unvaccinated people admitted to the hospital. We have only 1 in the ICU, but 7 others either on high flow oxygen or on BiPAP. And then just thinking about our hospital census, so though we have 176 licensed beds, only 159 of those are easily accessible for adult acute issues. The rest are mother, baby, or nursery beds. So of those 159 available beds, our census this morning is 152, so about 95% utilization of those adult beds. So COVID right now is accounting for about 9.4% of all of our beds, but our hospital remains very full. Because of that and our staffing challenges, we remain on a no inter-facility transfer status. We do try every day to evaluate every request, especially from our critical access hospitals in our region, and we will accept patients when able, but we do remain on that no inter-facility transfer status. Every stroke, cardiac, or trauma case that we get is request for transfer that we get is vetted through our ER docs to see whether they require immediate treatment in our facility. So we do those on a case-by-case basis. We do know of some patients being kept at our critical access hospitals that really should have a higher level of care just because there's no place in the region to transfer them to. And that's, providing a level of care that we don't want to serve to our people in the region. We want them to be able to get the appropriate level of care, and in some cases that's not happening. From a staffing standpoint, it continues to be very challenging. We continue to have high vacancy rates. We have over 110 nurse openings, which is about 18.5% of our total inpatient nurses. We have a lot of CNA and respiratory therapy openings as well. We did benefit from the Department of Defense team, which provided us with 20 staff in the month of November, but then they left. We do still have about 35 staff through the ACI and their contract with the Department of Health. So we're really happy to have those folks through February because that's allowing some of our permanent staff to get a little rest and relaxation that's needed. We still do have over 60 travelers in our inpatient facilities. And really, to stress everything that other folks have said, we're worried about a possible Omicron surge. We're worried about our ability to accommodate increased testing. We're really worried about its effects on our staff. And if our staff start getting infected, how are we going to be able to adequately staff our beds? So really want to, again, encourage everyone to get vaccinated, get their boosters. It's very easy, obviously, to let your guard down during the holiday seasons when you want to gather with friends and family. That's something that we all cherish. But the downstream impacts to our health system could be significant if we do let our guard down. So I think we have to take all those protective measures that we know are very effective in preventing the transmission of this. So that's the update that I have from Confluence Health.
Great, thanks, Dr. Lake. And one of the things that you said, which we've heard over and over again, but just sort of struck me in the moment, was the number of patients that you have in the ICU that are unvaccinated is really significant. Vaccines do work, and so we want everybody to stay out of these ICUs, and it's not a fun experience. So really emphasize that. And Dr. Lake also mentioned some of the effects of having really high capacity in our hospitals, which include challenges with transferring patients. And so this is a great time to turn it over to Mark Taylor with the Washington Medical Coordination Center, who can give us some perspective from where he is making sure that we are able to get care to patients who need it. So I'll turn it over to you, Mark.
Excuse me, thank you. And I appreciate the opportunity to discuss this a little bit. As was mentioned, my role, I have actually a couple of roles. I'm an associate administrator at Harborview Medical Center, also the director of operations for the Washington Medical Coordination Center. And I just want to give a little bit of background on that work because you've heard the panelists talk about some of the impacts of the pandemic, and not all of those are direct in terms of actual COVID patients that are presenting, but some of the indirect impacts also result in very, very high occupancy in our facilities, which the Washington Medical Coordination Center helps out with. So let me first talk about the fact that the idea between the Washington Medical Coordination Center, or idea of the Washington Medical Coordination Center, is to create a central point of coordination of patient movement throughout the state of Washington. And I think this is one of those areas, I think Taya mentioned earlier, where the hospital system is stressed but not broken. I I would state that this is one of the areas that I think Washington State has done extremely well in terms of coordinating distribution of patients, because Dr. Mint also touched on this aspect. The pandemic impact is not equally spread throughout the state. It is disproportionate. It disproportionately impacts some communities more than others, and as a result, we have communities that will be impacted severely with very, very high occupancy, or in certain circumstances, communities without high-level resources that need to transfer patients to resource facilities, higher-level centers that have those services available. What ends up happening then is those communities become saturated with patients, become somewhat destabilized and unable to effectively or efficiently take care of patients. And the resource facilities throughout the state, which there are not that many of, really become have extremely high occupancy, and as a result are not able to support their communities, at least to the degree that all of us would like to. And so the strategy for that is to move patients to a little bit farther, to facilities that are able to appropriately handle the services that are necessary to care for those patients, but also to utilize the community and rural and critical access hospitals to their capability as well. So to move patients who are less acute to those rural and critical access hospitals, again, so that the entire hospital community is supporting patient care to the degree possible, and for the services that are available in all of those facilities. This becomes extremely challenging in some circumstances where Dr. Lake mentioned somewhat geographically isolated communities with sort of a hub and spoke type model, where patients may be at a critical access hospital in that North Central Washington area and need to be moved to Confluence Central Washington Hospital for ICU level care or specialty services. But in those circumstances, Central Washington Hospital may not have that capacity at that time. So the Washington Medical Coordination Center role then becomes to distribute those patients a little bit further, hopefully to a facility that has that capability and capacity, and then again, leveraging whatever capacity exists within those community facilities to preserve capacity at those resource facilities. I think we've heard over and over again regarding the number of COVID patients that are existing in our state's hospitals at this time being relatively low. I would say that it is relatively low. It is not by any stretch absent. We still have over 600 patients, I believe, in Washington State hospitals being actively treated for COVID. That's not a small number. And I think what it adds to our nervousness in terms of the impact from this next strain and what our capacity will be to accommodate those patients that inevitably need care in our facilities. I think there is also a significant concern regarding the number of patients that are in all of our hospitals at this point in time. As was mentioned, when you look at the statewide average, you may see 97, 98% occupancy, but when you really look at the resource facilities with higher level services, ICUs, specialty services, the things that the patients may present with, especially in certain time-sensitive illness states, those facilities are reporting over 100% occupancy. And that is extremely concerning, given that the variant we know will require ICU level care for some of the patients that we have in our communities. And so I think obviously facilities have already been managing their census to the degree that they possibly can. That involves screening patients for care that can be delayed, to attempt to sequence that care to the degree possible. Again, everybody wants to make sure that care being provided is as safe as possible. But the only other strategy that we have in place to create census and capacity is really to look at patients who are eligible for discharge into the long-term care community and find them resources in that long-term care community so that we can create, again, that acute care capacity, especially in our resource facilities, to provide care for some of these community and critical access hospitals that are really require it at this point in time. And I think clearly, finally, just to pile on to what everybody is already talking about regarding general safety precautions, although we've heard, it's certainly been reported within the media that this new variant does not seem to be providing as serious an impact to patients. I personally don't believe that we really can afford to have much impact at all. Capacity is extremely high right now. And so to the degree that all of the members of the public can take precautions, every precaution necessary to prevent possible infection or development of serious illness, we absolutely need to do that. All of the strategies mentioned regarding social distancing, masking, vaccination, I strongly encourage people to do, because we really do not currently have the capacity within our facilities to accommodate a large surge, as we just came through with the Delta surge. At that point in time, we had over 1,700 patients in our hospitals. That would be adding on, you can imagine, 1,100 additional patients to Washington State hospitals from where we are currently. And the capacity currently does not exist in our facilities to accommodate that kind of patient demand. So I'll stop there. Certainly take questions later on.
All right, thank you very much. That's some really important perspective to provide from the folks who are the ones in charge of finding the spot for someone who's going to need it when they require a higher level of care. So from here, I'm going to go ahead and move to Dr. Diaz. So thank you, Dr. Diaz.
Hi, thanks so much for having me. I want to describe what's going on in my community here in Snohomish County. My hospital, Providence Everett, has 600 beds. And in the county, in Snohomish County, there are less beds for skilled nursing facilities now than there was a decade ago. That is despite Snohomish County growing at a very fast rate, approaching 1 million people, and we serve an area over 1.2 million people that come to our hospital. This has been an issue with long length of stay for quite some time. As far as I can remember, we've had issues with being able to move patients from the hospital to a skilled nursing facility. When we speak to our partners that run these facilities, they are also having staffing issues. They have a few open beds, but they don't have staff for them. There aren't enough adult family home beds in our county to accommodate the number of people that we have in our area. And even the reimbursements for these facilities is not great. So it's hard for someone to come in and, make a new nursing home, because it just doesn't, you'll lose money doing it. And the result is that now we're in a crisis with hospital capacity. My hospital of 600 beds, over 100 of them are patients that no longer need to be in the hospital, that are waiting for a skilled nursing facility or an adult family home placement and simply can't be placed. We don't feel that the alternative is to discharge them. It's not safe to send people home that have nowhere to go, or it's unsafe to be where their home is. And so they're now in the hospital. As everyone in Washington State is struggling with staffing, we are caring for 100 patients in our hospital with limited staff that have no place to go. What this means is that it takes away from some of the resources that we need to be able to provide other types of care. We have a number of patients who are waiting for surgical procedures, for example, and on a daily basis, our leadership works with our surgeons to figure out if we actually have space for these patients that need these surgical procedures. And in many cases, these procedures are being postponed. And these are not trivial procedures. These are people that have cancer that need to have tumors resected or need to have a heart bypass surgery. And they're being postponed because our hospital is full of patients that really ought not be there. This also reduces the amount of people that we can see overall. Recently, we were unable to move patients from our ED to an inpatient bed, and so we had a large number of people staying in our ED for a really prolonged period of time because there were no beds in the regular parts of the hospital. And this reduces our ability to be able to do these elective or semi-elective procedures in a timely manner, and it potentially could affect us being able to care for people if they come in during a new surge that we anticipate coming over the next month or so. So this is a crisis that we're dealing with. There's not an easy solution. We don't have the resources in our county to simply move them out of the hospital without state help. And we're really appreciative of the Washington State Hospital Association to really focus on this, because this is a crisis. This is a crisis not just here in Everett, but across the entire state that needs to be addressed. It's a confluence of lack of resources and committee for all these patients. We're 2 years into the pandemic. Many nurses and other healthcare providers are leaving the profession because of the stress that they're under at work and the trauma they've experienced over the last couple of years. And so all these factors are coming all at once, and really it has become a crisis for our state and especially for Snohomish County. There are certainly things that people can do to help, and as mentioned earlier, vaccination and boosters are the absolute best things that people can do now to help us prevent admissions. In Cleveland Clinic and other partners put out an ad saying help as a full-page ad begging their communities to get vaccinated. Thankfully, we have some communities in Seattle that are well vaccinated, but even in my county, we still have large pockets of people that are unvaccinated, and we continue to struggle with getting those vaccination rates up that we know that can prevent hospitalization. So as much as possible, we really ask and urge the public to get vaccinated if not already. We're grateful for the therapeutics that have come on board that have been approved. We have several new ones, the oral antivirals. We don't yet have them in hand, and those are being allocated by the state. And frankly, although they're exciting because some of them appear to be effective, the number of doses that we'll be receiving from the federal government is probably not going to be anywhere near to address the number of people that actually get infections. And so this will be another challenge for us, dealing with these other limited resources that will shortly be available, but not for everyone that needs it. And so the best thing we can do is to prevent infections to begin with. Thank you.
Thank you very much, Dr. Diaz. Appreciate those comments. And we are starting to see some questions pop up. We'll go ahead and work our way through those. The first question is, the health department data dashboard shows that hospital occupancy has not gone down statewide since the Delta variant surge, despite COVID hospitalizations declining. Why is this? Is it staffing shortages, more people seeking delayed care, difficult to discharge patients, or all of the above? It is some of all of the above. And the thing that we are experiencing most of and that is having the most significant effect right now statewide overall is difficult to discharge patients. This is the type of problem that has always been a challenge for our health system, and it has become greatly exacerbated during the pandemic. Earlier in the pandemic, we were able to decant some of our hospitals with increased efforts by our state partners, working through the assessment process faster, increasing payment rates for nursing homes. Some of those steps are again being taken, and as I said earlier, really appreciate those efforts by our state partners and really want to encourage them to step up or redouble efforts to make that happen. Another really important change with these difficult to discharge patients needs to happen in the state law. Right now, when a patient needs to be moved out of the hospital but might have some cognitive challenges and not be able to make decisions for themselves, it requires a guardianship, which is a really intensive, expensive, time-delayed process in our court system. The law allows for people to rely on a family member, a surrogate decision maker for major healthcare decisions like surgeries or even end-of-life care. But if you want to get transferred to a long-term care facility or need to be transferred to a long-term care facility and have cognitive challenges that don't allow you to make the decision for yourself, you need a guardian. And that just doesn't make sense to us. So that's one of the law changes we'll be seeking during the legislative session. Do any of our panelists have anything else they'd like to add to this, to the response to this question?
I would only just add one more, and completely agreeing with what Taya said about the need for better workflows, change in the rules and regs to allow us to be able to move patients out of our acute care facilities that don't require that level of care, so that other patients can get in. But I'll also comment on the question that during the Delta surge, we had deferred significant surgeries, and Dr. Diaz mentioned these. These are like, you know, a breast mass picked up in a mammography that we want to biopsy and make sure if it's cancer or not, or a different type of lesion. And we had to defer some of those during the Delta surge when so large of a portion of our patients in the hospital were COVID. So we're actually trying to get those patients now taken care of, some of which need hospitalizations. And that's also part of why we're not seeing that overall decrease. We're just continuing to be, you know, to move that backlog and hopefully get to all those patients that get the care that they're required. But that's also part of the reason why we haven't been able to decrease the overall hospital census, even despite being past the Delta wave. And we're trying to prepare for what could potentially be any effects of Omicron.
Thank you, Dr. Mint, for that additional perspective. And the next question is also for you, Dr. Mint. How close is Multicare to needing to send patients out of the area?
Great question. You know, what Mark mentioned is that we are blessed in Washington State to have a community, and Multicare luckily has multiple facilities. We have 11 hospitals within Washington State. So in the regions, we level load our hospitals within our own system to try and manage those patients, to get the right patients to the right level care. Some of our hospitals are more community-based, some have more specialty care. And to Mark's earlier conversations, we want to reserve some of that specialty care that, for example, George Diaz or Jason's facilities may want or need or have those capacities for. So right now, we are not thinking that we are going to need to move patients outside of our system, but our overall capacity, it's a constant moving of patients from site to site, triaging from the different emergency departments. And many of the patients in our facilities, as Taya mentioned, don't need to be in the hospitals for their conditions that they have, but are in our hospitals because the next post-acute facilities or care sites just don't exist right now for all the reasons that Taya mentioned.
I think if I could add on to that, I agree completely. I think from what we are seeing is the large hospital systems like Dr. Mintz, like Multicare, are able to, within the hospital system, are able to distribute patients among those facilities very effectively. And in fact, even in addition to that, even support the community and community hospitals outside of their systems. Where we really see struggling is when we have facilities, particularly rural facilities and critical access hospitals that are not associated with larger hospital systems that really are going to need to rely on larger hospitals to provide that specialty service care or higher level of care to take care of the patients in their community. Those hospitals play a vital role because they are, in fact, the supporting healthcare organization for those communities. Frequently, they are very geographically isolated, and the closest available facility may be the closest resource facility available may still be a significant drive away, 45 minutes or an hour. And so when we start to have to look to move those patients beyond that closest available resource facility, it really can become challenging in terms of patient safety, and to the degree that we want to avoid that for efficiency, for patient safety, ultimately that's best. So any attempt we can to manage census and create capacity in those resource facilities for the rural and critical access hospitals that are standalone, that are geographically isolated, it's extremely important to us.
Thank you very much for that. And the next question is, given the current situation, how concerned are you that Washington hospitals might meet or reach crisis standards of care? And I will provide a response, and then I would like any of our panelists to provide any additional insights. I will say we need to be doing everything that we can right now to keep the system from tipping over into crisis standards. Washington State is one of the leaders in the nation in working together to avoid crisis standards. We have agreements between our hospitals that no hospital will go to crisis standards on its own. And the Washington Medical Coordination Center is key in preventing that from happening for all of the reasons that Mark did such a great job describing, level loading the patients, really being in close communication with hospitals about what their needs are and where there is a bed available. That doesn't necessarily happen in other states. And in fact, I think it's unique that we do that here. And the level of commitment that we have had from our hospitals is extraordinarily high. And we're worried. We have been preparing for crisis standards. We have recently rolled out with the Washington State Department of Health a new set of guidelines for implementing crisis standards, and hospitals are studying and preparing for it if we need to go there. As I said, we're going to do everything that we can to prevent it, and we will, if we need to go there, do everything we can to make sure that the hospitals and health systems are prepared for a situation where we may be making decisions about who gets a scarce resource like an ICU bed or a ventilator. We want to avoid it. We're doing everything we can to avoid it, and we're getting ready. So any other comments from panelists?
I would only mention that, you know, there's different reasons why healthcare systems might slip into that. And I just want to emphasize what Taya said, which has been one of the real things that I'm thankful for this whole crisis, was how Washington State is really all in it together. And we've been able to avoid what other states have hit. What I would say is that the different levers that might tip folks in historically has been in regards to beds or ventilators or those. What we're really running into is a staffing crisis now, and especially with Omicron and its ability to infect folks and have some probably a higher rate of breakthrough infections than others. Staffing through the holiday season is really going to be important, and we're working really closely with our staff to make sure that they're staying safe, they're getting their shots and boosters, but also that you know, we're getting enough testing capabilities in to make sure that our staff, you know, are not sick when they come and take care of patients. But also the national guidance in regards to the evolving science on how long folks have to be isolated and or quarantined are things that not only are we looking at on the federal level, but also on the state level, and with our disaster management and Washington State Hospital Association colleagues. All those are going to be really important in making sure that our staff are safe, healthy, and to Jason's point, you know, resilient and ability to keep coming and taking care of our other communities.
Great, thank you, Dr. Mint. And this is a question for Dr. Diaz. Of the 600 beds that you mentioned, how many are filled with COVID patients, and how does that compare to previous peaks? What is the overall capacity?
So our COVID census has been relatively stable over the past few weeks. We've been running between 40 and 50 COVID patients in the hospital. About 15 or 20 of those have been in the ICU. And that's much less than what we had at the peaks of the pandemic, where we would have over 100 patients. So, you know, we're obviously very worried about a new surge with Omicron, but the major problem for our hospital is the ability to discharge patients. We have over 100, probably closer to 120 patients currently in the hospital that have nowhere to go, that don't need to be in the hospital. And among those, roughly 50 of them are patients who need adult family home level of care, which is pretty minimal care overall. You know, they for the most part, they can live on their own, but they do have some needs. And with staffing the way it is, the leftover capacity is actually pretty small. You know, and I think as a state, we're working very closely and well together. But the amount of cushion that we all have is probably pretty small for the state, and that's why it's so important to deal with this now, to address this, because we really don't have a lot of cushion and capacity left over to absorb a large wave of patients. And this definitely does affect other services, not just here, but any healthcare system that you're talking about in the state is similarly affected with being able to deliver care that's important at a personal level. The patient with the breast tumor that Dr. Mint mentioned is hugely important in the life of that person. And what is preventing those cases from moving forward in a timely fashion is that we're not able to discharge patients that don't need to be in the hospital. So we do work together, but this is a major issue for us in Sonoma County.
Thank you, Dr. Diaz. And the next question is, what does the legislature need to do to address the inability to discharge patients to alternate care? Can the governor use his emergency powers to take care of some of this? So great question. This is one of those challenges that has multiple factors to it. So multiple things need to happen that can, some of which can happen now, even before the legislature convenes, and some that need to be, some actions need to be taken by the legislature or furthered by the legislature. So one of the issues, as Dr. Diaz mentioned, is sustainable funding for long-term care facilities. It is really challenging to provide adequate payment rates right now for those staff in long-term care facilities, which makes them hard to staff. So in order to both recruit and retain the staff necessary for those facilities, we need increased payment rates for those facilities. Another challenge in this process is getting assessments done on those patients who need to transfer out. It takes staff time at the state to do those assessments. And so increasing the number of staff that can do them, having them work longer hours, hiring more staff at the state that can do the assessments, that's another piece that can be started now and needs to be adequately funded and resourced by the legislature. And another issue with respect to the law change that we need with respect to decision-making for moving these patients to long-term care, to that appropriate care setting, the governor could potentially act using his emergency powers right now, but the legislative session also is not far away. And so either option sounds really great to us. We just want to see action as soon as possible on this measure. Because right now that is a piece that doesn't make a whole lot of sense to us and is preventing patients from moving out. So as I said, multi-factor, challenging situation with multiple things that need to happen. Okay, yes, please go ahead.
I just wanted to comment on that because, you know, there's two aspects of this. One is a long-term aspect of the fact that, you know, we need to have a sustainable system in our communities, which is not the case. Even if rates were improved and facilities were able to hire staff, we still don't have the number of beds needed in our community to put them. They just don't, they literally do not exist. So while we welcome and need improved funding and improved staff to get people assessed, we need physical space to send them to, which doesn't currently exist. And that is, I think, part of the urgent problem that we have is there's really nowhere to send them. Even if we could, there is no physical place to put them. And I think that's where the governor could really help.
Thank you, Dr. Diaz. That's great additional perspective. And then our next question is, I believe Taya touched on this, but just to confirm, we have not yet seen COVID hospitalization spike likely expected as part of an Omicron surge. How confident are hospital leaders that the state has enough resources and supplies to make it through new spikes, mostly referring to masks, gowns, other PPE, not with respect to staffers? The question really is about supplies. And so I think we are seeing COVID hospitalization, Omicron related hospitalizations, but the peak that we've been talking about coming has not yet hit, or the surge that we've talked about coming has not yet hit from Omicron. We're trying to get ready. I think with respect to the supply question, you know, PPE and gowns and gloves and so forth, I'll refer to our panelists, or if you have anything else you want to comment on, please go ahead.
This is Mike from Multicare. I'll only just briefly say that the supply chains, there continue to be supply chain disruptions throughout all of our supply chains, things like vacuum containers and those. PPE in general, we've been better off because most healthcare systems, and my colleagues can speak for theirs, have really kind of been able to restock and resupply those. So we don't think that that's going to be rate limiting through Multicare and other healthcare facilities that we've been talking through.
I'll just comment. So I know they said don't comment on staff, but staff really remains our biggest issue. So that's going to be our biggest challenge. But outside of that, I agree with what's been stated in terms of other PPEs and supplies. I do have concerns just about the logistics and our ability to accommodate a significant increase in testing demand. You know, as we enter the respiratory virus season, and with the likelihood that Omicron may have a different or more widely variable degree of symptoms in patients. So a lot of patients with mild symptoms, and they don't know if it's the regular cold or COVID. And we as a community health standpoint want to know if it's COVID so we can isolate those people accordingly. And then also we have new Osha guidelines that are supposed to take effect in January, where large employers, if they have unvaccinated individuals because they have an exemption, have to have a testing regimen for those employees to be able to go to work. And those large employers, at least in our region, are looking to partner with someone to help them in that testing capacity. And we as a health system, we have to focus primarily on sick people and testing those. So I'm not sure we can partner with those large employers just for screening testing for them to go to work. So we're trying to figure out how to navigate this, you know, the likely significant increase in testing demand that may happen over the next few weeks.
Yes, please go ahead.
I can just comment just briefly on the surveillance of the communities around the state. We do watch that pretty closely. It is extremely difficult at this point in time to get a clear signal that we're seeing a rise in hospitalizations in any one area, with the possible exception of South King County and Pierce County, which is showing increase in hospitalizations due to COVID patients. And again, it becomes a little difficult because COVID was not previously gone, so we were still seeing impact from the Delta surge that we saw during the summer into the early fall. And we also just had a family get together during the Thanksgiving holiday, which could be creating some of this impact as well. But we do know that we are seeing an increase in South King County and Pierce County regarding COVID patient care at this point in time, which absolutely could be the beginning of the impact from the new variant.
Thank you. Great additional insight. And the next question is, can you highlight what the current hospital occupancy rate is statewide? No, you did not miss it. I missed it. So right now, hospital ICU capacity is about 10%, meaning that there's 90% occupancy statewide. Hospital acute care capacity is 8%, meaning 92% occupancy. And I think it's important to highlight what I think Mark mentioned in terms of really one of the biggest challenges is that high level care at some of our facilities that are over 100%, and inability to access that really higher level care for the patients who need it. So while statewide, we may be able to, say, looks like there's a little bit of room here in those higher level facilities, there may literally be no room. And so that's one of the challenges that we're having. I'm going to go ahead and keep moving because I know we're even over time, but I want to see if we can get to all the questions that we've got here. Percentage of elective surgeries that are being delayed or postponed, is there a way to put a number on this? I'm not sure that that is something that we actually quantify. So if our panelists have any response to that, please go ahead.
This is George. I don't have a percentage, but it's significant. Any of these is significant because it means someone is getting delayed care and adding to their burden of disease.
Yeah, and it is terrible for somebody who has cancer to have a surgery delayed, or somebody who needs a heart procedure to have their procedure delayed. And it's also horrible for the clinicians that are needing to make that decision to delay. And it is leading to significant fatigue for those folks. So I want to recognize that on both sides.
And I'll just add one more comment to that. The other reason that it is difficult to estimate that number, at least in our system, is some of our surgeons actually, as their surgical backlog continued to increase, they modified their clinic because they didn't want to see patients in the office and just add them to the backlog without knowing when they would actually be able to get their surgery. So there are people that still haven't even been seen for their initial preoperative office visit. So those people are uncounted in any known list of backlogs that we have. So it just complicates it.
Yeah, and I was going to emphasize what Jason just said, and I think it bleeds into the next question from Tom, in that I think that there is a huge amount of deferred care. This includes primary care visits to go in for screening, well child checks, and lots of other preventive health. And I believe that those are other reasons why working on a lot of the things that we've talked about today to unburden the healthcare system has an effect to free up the ability for us not just to get in those hospital-based patients, but also clinic-based patients, because we've been having to redistribute staff to make sure that the maximum benefit to our patients and communities, but that sometimes leaves other parts of the system uncovered. And that includes a lot of really important primary care that needs to continue to happen, and we need to make it safer for patients to be able to come in and get that primary care. So it's really a 360, and those are fantastic questions, because we need to continue to free up our healthcare system so that we can not only take care of hospitalized patients, but also the broader community.
Thank you for that reminder. It's so important. We're not just taking care of COVID patients, we're taking care of the entire community. Any other perspectives from panelists on that question about non-COVID related deaths from delayed care? Okay.
One more question, one more sort of.
Go ahead.
For my county, that's I think about 800,000 people, and we serve about 1.2 million people. We're talking about 100 people that are drastically affecting throughput for the healthcare system. So relative to the entire population, this is a really small number of people that is having a drastic effect on our operations. So hopefully we can address that, because it's not a vast number of people we're talking about.
Yes, thank you for that perspective. I think if you think about, there's one hospital bed, and the average length of stay for a hospitalization is usually a few days, and somebody is occupying that bed for 100 days, or in some extreme cases, more than a year. That's a lot of patients who should have been in that bed receiving care that never had a chance to get it. So, okay. Thank you. I've got a last process note, a little prompt here on the topic of crisis standards of care, back to that topic. And just a reminder, process-wise, while hospitals are doing all they can to avoid it, it is a declaration that is made by the state. So when we go there, if we need to go there, that will be a decision that is made at the state level. No individual hospital is actually going to be in the role of making that decision. So just a process clarification there. I think we have exhausted the number of questions that came in through chat. We're over time, but if there are any other quick questions, please go ahead. Okay, I want to give a big thank you to everyone who attended the media briefing. Thank you for helping us get these really important messages out to our community. Our plan is to be back to you on January 10th with another briefing. Thank you very much to our panelists. Super smart, super dedicated, incredible folks who are serving their communities. Thank you to each one of you. And that's it. We'll talk to you in the new year.